obviously. And if you forget, it's right here. I'm Dr. Valerie DeLuca. We're going to talk about cancer detection and screening and prevention today. And if you were here last year, I'll try not to bore you because it's similar. Things haven't changed that much in this world in a year, but they have changed a little bit. So how many here have heard of cancer? All right, so just real quick, a screening test is done when you do not have symptoms. And the only reason I bring that up is that, I hear a lot in my office when I ask if they've had a colonoscopy, particularly, and they don't want to have one, and they'll tell me, well, I don't feel anything, and I'm not bleeding, and I say, well, if you were doing that, you already have cancer, there's no reason to screen you. That's diagnostic. This is to catch disease before disease happens, is the whole idea. So, there's no perfect screen. The best screen is the one that only detects when you have the disease and tells you don't have it when you don't have the disease. Nothing quite reaches 100% in those arenas, but we try to do the best we can. So, as you can imagine, that's based on statistics and analyzing statistics. So, when you're in with your doctor and you're a population of 1, you're not a statistic. But when we try to recommend what's best for you, we're basing it on statistics because that's really all we've got. So, so everything that I tell you today will always have a caveat. Of course, you need to discuss this with your doctor and see if you both agree that you're at the same risk level that you think you are. All right. It's kind of hard to see, yes, or is it just me?
Very wide.
Yeah, not sure what happened. I tried to change up the design and it's a little light, but so I'll try to say everything that's important on the screen without reading it to you. So let's start with lung cancer screening. So this is still, it's still new. It's probably one of the newer cancer screenings that we have, and it's a little bit controversial for that reason. Not that they all aren't. But lung cancer screening, we only do it in smokers. Doesn't mean that the rest of us can't get lung cancer, but smokers obviously have a much, much higher rate. And we do it, it's recommended by most doctors between the ages of 55 and 80 who've had a 30-pack year history. And for anyone who doesn't know what that means, it's the number of packs of cigarettes you smoke a day times how many years you've smoked. So if you smoke 2 packs a day for 10 years, that's a 20-pack year history. So anyone with 30-pack years, and they've smoked within the 15 years. So it's not 30, I smoked for 30 years, but I quit 20 years ago, you wouldn't really qualify for this screening. So there are other things that make you at risk for lung cancer, even if you're not, a screening candidate. But those are much less than smoking. Smoking is number 1 with a bullet. But there's a thing called radon, which you don't hear much about. It was big in the 90s. It was leaking in people's basements, mostly up in the Northeast. Family histories, there are some obviously genetic ones. They're not as strong. They haven't actually identified a gene. And then there's occupational risks, people who are around certain chemicals. Hopefully not so much of that anymore, but sort of historically. So you're supposed to screen, when you do screen a smoker who fits this category, or a past smoker who fits the category, you do it every year with what's called a low-dose chest CT. So there's obviously a radiation risk whenever you get a CT exam of any sort, but a low-dose chest CT is the lowest they can get away with and still get a good screen. And it has to be at a specialized center where they are trained to read these kinds of chest CTs. And I want to say that I spoke with our radiologist last year about this, and they said that they don't really do it. So if this happens to fit you particularly, we may have to send you to a center if we feel strongly you should have that. But I will tell you that it has a very high rate of false positives, as you can imagine. We're going to see more if we look more. So lots of people have things in their lungs that are nothing, but if we go looking and digging around, we're going to find something a lot of times, and then we have to biopsy you, and it sets you up for a lot of testing that may or may not actually be indicated. So that's why the controversy. So any questions about that before we move on to
I have a question.
Yeah.
Someone that, what's the right word for it, dips or puts tobacco in their mouth.
Right, smokeless tobacco?
That's younger than 55, is that, that could create problems eventually, maybe, that tobacco?
Yes, mostly head and neck. You're at very high risk for head and neck cancer, squamous cell specifically. My grandfather did that and he died of lung cancer, so I don't know if he, I never met him, but he may have smoked too, I don't know that, but there's no official increase in lung cancer specifically. Cancer, yes, and probably much higher for that squamous cell, yeah, it's not, that's another one.
Thank you.
So, as far as lung cancer goes, it is the highest rate of cancer deaths. It's 13% of all new cancers diagnosed and 7% of all cancer deaths. And think about how many cancers there are. It's more than breast, colon, and prostate all together. And obviously, the best thing you can do is to stop smoking if you do smoke. And that includes secondhand smoke, which is a lot harder to get than firsthand sometimes. And if you were unlucky enough to work around asbestos in your life, if you smoke, you have increased your chances more than double by doing so for cancer. Okay. Colon cancer. Not so much tied to bad habits. We don't know exactly, but we think that diet is somehow heightens your risk if you don't have a lot of fiber in your diet. Your biggest risk is getting old. When we all get old, we all have a higher risk of getting colon cancer, so you can't really stop that. We start screening normal risk individuals at 50. And normal risk individuals do not have a tertiary relative who had early colon cancer. They don't have any kind of genetic disorder. They don't have inflammatory bowel disease, which is ulcerative colitis, or Crohn's disease. Forgive me, I got very little sleep, so I'm having a finding issues. So, if you have those, you will already be seeing a specialist and you will know you're very high risk for colon cancer. And so they screen, those people get screened pretty much by the time they're 20 if they're diagnosed that year. But all the rest of us get screened starting at age 50. And then it will be every 10 years if you have a normal colonoscopy. So I always tell my patients, you're getting the biggest bang for your buck there. I mean, there's no cancer screening test the last 10 years, other than a good colonoscopy without any polyps in any of the findings. If you did have a family member who had colon cancer and they were younger than 50, or if they were 50, we start 10 years younger than the age that they had it. So my father got colon cancer, he was diagnosed at 50. I'm going to screen you at 40. If your brother, they found colon cancer at 30, I'm going to screen you at 20. Because it takes 10 years for a polyp to become cancer, is where we get that from. So people who have really young base colon cancer, we screen earlier. If you have a familial genetic predisposition, and there are two big ones, then everybody gets screened. As soon as we know you have that, we start screening you. There's one that causes a lot of polyps, and it's, they see it, they go in to do the colonoscopy, and they stop counting because they get to 100 pretty quick. And so then there's another one which causes other kind of cancers. It's called Lynch syndrome, is the easy way to put it, or HNPCC. Those people have they have colon cancer, uterine cancer, gastric cancer. There's a lot of different cancers involved in it, but typically you'll know. You have first degree relatives and second degree relatives, all through the generations, they all have cancer. So typically you'll know that. Of course, that doesn't mean you're not the first person. You could always be the second case. So, but typically we wouldn't catch that with a screen because we wouldn't be expecting it when you're 30. All right, so we believe that colon cancer screening, better colon cancer screening, has lowered the death rate for the last 20 years. We can't prove that was the only thing that did it, but we believe that that's why the death rate's gone down. So it still has a heavy prevalence. It's still number 2, but death from colon cancer has gone way down. All right, so this actually I missed it, and I just found this out at my conference. So the screenings are a colonoscopy every 10 years, a flexible sigmoidoscopy every 5 years, which is, we don't do them around here, but we used to do them all the time in the office. And it's basically just you visualize that last third of your colon. It doesn't go all the way around. That together with a fecal occult test every 3 years, which is weird because the math doesn't add up. It's like hot dogs and buns. But that also is equal to colonoscopy every 10 years. We do not do double contrast variant anymore. There's no more of that. because radiologists don't do them anymore, nobody reads them anymore, it's just an old-fashioned test, so that won't happen anymore. You can also get CT colonography every 5 years. You won't find a lot of it around. It works, except for if they find something, you still have to get a colonoscopy screen. So you still have to do the prep for the colonography, and then you got to do it and get a colonoscopy. So, and then you could also elect, it's not as great, but you could also elect to get the fecal report every year. And there's some people who really just, no matter what, I can't talk them into a colonoscopy, and that's what we do. The only problem with that is that we're only screening for blood when you already have cancer. We're not screening for polyps. I have no idea knowing if you have a polyp by doing that unless it's already bleeding. So, as you can see, that's not perfect. All right. So prevention, as far as we know, are the boring things. Maintain a healthy weight. Have a great diet, high in fiber, fruits, vegetables, whole grains, less red meat, less smoked meat, less grilled meat, less fried meat, all the fun stuff. Be physically active, don't smoke, and don't have inflammatory bowel disease or family or household. So we call those the unfixable risk factors. 2 males in the room? Okay, well that's better than last time, I think. All right, so prostate cancer screening, also you may have heard about it in the news. It's very controversial because they recommend it, they don't recommend it. So the recommendation now is that average risk men get screened at 50. Higher risk men, typically 45 years old or as soon as we know. But really, younger than that is, we don't get a high yield for it. So the recommendation now is that this is a conversation between you and your healthcare provider. And it's because we may find something that we think is something, it isn't anything, and the testing to find out if it's anything is pretty invasive. And so we're talking about incontinence, we're talking, big time risks. So we have the conversation, you and I agree that you are very high risk and we're gonna do it. So the screen is a blood test and an exam. Together gives you the highest specificity and sensitivity. If you are high risk, that means that someone in your family had prostate cancer, and it's a first degree diagnosed before age 60, or a first degree that died before age 75. But no doctor's they're just going to say, yeah, your dad had it, we're going to, I recommend screening. You're high risk. Or African American men just in general, all gets considered high risk. So after you discuss that, we do a PSA, which is a blood test, and then a digital rectal exam. And if anything is abnormal, you go see the specialist, and then a biopsy is in your future. All right, same boring things, you'll hear this a lot. Maintain a healthy weight, don't smoke, limit your alcohol. We don't know why, but there is a higher risk geographically for prostate cancer. And, again, it's one of those things, we're not sure why. So Asian men have the lowest risk, and African Americans have the highest. And it's another cancer where the older you get, the more at risk you are. Okay. And breast cancer screening. So this also changes frequently. So you should have a yearly mammogram starting at age 50 or age 40, depending on who you ask. And all of the different societies have a little bit different recommendations, but definitely by 50. And even the ones that don't recommend it starting at age 40 recommend that you have the conversation if you believe you're higher risk than normal. And you should have a mammogram every year or every 2 years from age 50 or 40 to 75, depending again on who you ask. You should also have a clinical breast exam every 3 years between the ages of 20 to 40 and then yearly thereafter. And this is kind of one of those things that's gone by the wayside, because for a while they weren't recommending that at all. And even though some of them say 40 to 50 to 75, it's basically based on your lifespan. So colon cancer is like this too. I'm not going to screen you for colon cancer if you're gonna pass away from something else this year. because that yield is so low for you, why put you through that? But if you have 10 great years left in you, then it's worth a screen probably. You know, even though the recommendation from the U.S. Preventative Task Force is to stop, we don't have to do that. If we both feel like you deserve a screen because you're doing great and you can survive any treatment from it and that's what you want, then we screen. So basically, it's another conversation between your provider and you. So when your lifespan is limited by something else is when we stop screening your breast cancer. So we've all heard about the high-risk genetic reasons for breast cancer, the BRCA1, the BRCA2, and then there are other ones as well. That accounts for a very small proportion of breast cancers, but it makes you such a great risk that those people obviously need to be screened very closely and surveilled very closely. If you've had any kind of radiation treatment, mostly for lymphoma, it's a young person's disease, then that puts you at greater risk and you need to be screened very closely. So in prevention, again, maintain a good weight, lower your alcohol use. And for us women, that's 1 drink a day. For men, it's 2. Get a lot of exercise. Avoid long-term, I don't have a minute right. Did I do that? Hopefully not. Hormone replacement, sorry, that's what we were talking about. So the deal with hormone replacement is that we should use the lowest dose for the shortest amount of time to decrease your risk of breast cancer. And so it's not, just avoid it altogether, but if you need it symptomatically, the lowest dose for the shortest amount of time, keep your symptoms away, and we continue mammograms. Breastfeeding confers a good risk for you if you did that, and having children before you're 30. Again, hormonal changes that help. All right, so unpreventable breast cancer risk factors, obviously your genes, as always, that prior radiotherapy. If you've had early menarche and late menopause, so the longer your cycle years. No children before age 30. DES exposure is just kind of going by the wayside. That would have been, so it's your mom's exposure. This was something they gave during pregnancy, and it was given in the 60s. So it's women kind of my age and a little bit older, so 50s and 60s, puts you at risk if your mom had DES. Race, unfortunately, it's another African American women have worse outcomes. Gender, being female, although men get it. Your age, it's another one. The older you get, the higher your risk. And having dense breasts, and that simply has to do with mammography. So the denser your breast tissue, the harder it is to see a lesion versus the actual breast tissue. So not being able to visualize it as well makes you higher risk. So then for a while they were kicking around the MRI thing. Should I have an MRI if I have dense breast tissue? And the answer currently is no, it's not recommended across the board, but they are coming up with new modalities. And if you do, I mean, it's something that typically your doctor and you would discuss if you need something more than a mammogram. Questions? So I just plowed through 2 with that. Okay. Cervical cancer screening. All right, the Pap smear. So the Pap test has been saving lives now for about 50 years. We start the Pap test at 21 years old for everybody now. There was a time when it had to do with when you became sexually active, and we found that younger women tend to clear this virus on their own without us having to take big chunks out of their cervix. And so we leave it alone. We don't screen at all until you turn 21. Once you're 21, so this is the most complicated screening guideline. So 21 to 29 is every 3 years, if you just have the Pap test without the HPV, the virus test. If you do the HPV, then I think it's still every 3 years, but that changes with age. So then when you're age 30 to 65, it's every 5 if you do both, or every 3 if you don't do the HPV. Yeah, so you don't need to memorize all this. Your OBGYN will know all that, or your family practice doctor. Over 65, you can actually stop if you've had regular screens before this, you haven't had any recent abnormal paps, you had a hysterectomy for non-cancer reasons, you can stop having a pap smear. And if you did have an abnormal pap, you can stop 20 years after that, which, you know, depending on when that is, you can do the math, it could be ridiculous. But I would still have one if I had an abnormal pap. So if you had a hysterectomy for cancer, they will still do the pap test. They do it on the cuff. They still, even though you don't have a cervix, they still do a pap test. And just another word on that. So we are talking pap, we're not talking pelvic exam. So even though you don't need a pap test doesn't mean you don't need a pelvic exam. They still recommend that. And what, you know, you have to consider is that vaginal cancer is not that common, but it does happen. If you still have your ovaries, a manual exam is still the best way to detect that. So it just means the actual test, the pap test. All right, so high-risk people are in a completely other category, and that includes mothers who use DES and immunocompromised, and I mean like HIV, not just taking prednisone, really, because they have very fulminant and terrible cervical cancer. All right, skin cancer. All right, so there's 3 kinds of skin cancer, as we all know. Some deadly, some much less deadly, but no fun. So they do still recommend that you do a self-skin exam. Everybody should do a once over. If you're high risk, they recommend it once a month, meaning that you examine every part of your skin. Mirrors, you want to see at the bottom of your feet. You know, you want to see this part that you can't see. You want to see every part of your skin, because melanoma can show up in very terrible places that you don't see. Your doctor does not usually do it routinely. It's not recommended still for, say, me to do people who are average risk as part of your yearly physical. But if you are high risk, meaning that your family has a history of melanoma or you have atypical moles or something that puts you high risk, you should probably have a good relationship with your dermatologist, and they will recommend routine skin exams for you to do at home, and sometimes they even photograph and the whole book of what your moles look like now. And everybody should know the ABCDE rule. You guys know this? For melanoma, for moles, for skin lesions. All right. So let's see if I can remember acronyms. That's all I'm saying. All right. So that's kind of stuff.
Well, this is an issue. I'm seeing a surgeon now because of some of these
Oh, very good.
skin issues. Well, I have melanoma in the back. So.
Oh, well, very good. Good for you. I was gonna say, I have pictures. I want to go to these first. All right, so here's some melanomas. So we're just gonna go right to that. All right, so you can see something right off the bat about these. So size is that first screen, right? So anything really over like a pencil eraser size is what we always say is concerning. Anything that has different pigments in it. See how this is 2 different pigments? Or a weird pigment. It's purple, it's blue, it's green. It doesn't look like a mole. It's irregular. See how the border is, it's not perfectly round? That's concerning. And anything that evolves, so that being the last one, anything that looks different. It was just this little thing, and now it's like that, Doc. That's concerning. Or this was on my face, it was always fine, and then I shaved it off, and now it hurts. It's concerning. Anything that evolves over time. And most of the time, it does look like one of these, and we know for sure we're scared, and somebody will take that off immediately. Sometimes we're not so lucky. Sometimes it doesn't fit the pattern. sometimes it's on the bottom of somebody's foot. Sometimes it's in their fingernail, or God forbid, the eye. So, it's a scary disease, melanoma, but most of the time, it looks like this, and we catch it, or somebody catches it for you. It loves to be where you don't look. I don't know, that's not really true. It just happens to, I had a patient hand her bra. Luckily, her daughter saw her. She probably wouldn't, I would never see that. So anyway, so that's the worst kind of cancer. Now, the other cancers are squamous and basal cell. So, and these are caused by sun exposure as well. They're invasive, not so much what we think of as malignant. That's still considered malignant too, but not fun. So this little guy, this little basal cell could be like just a tiny thing under someone's ear. They leave it alone, it can become the whole ear. So it's not something you want to take lightly. You want to get that taken off as well. And then the squamous cell is more of a rough appearance over there, and it starts with this precancerous lesion in the middle called an actinic keratosis, which we see all of the time, almost uniformly. Okay, so, and I think we know we're supposed to stay out of the sun whenever possible. Use sunscreen every day, even if it's not a beach day, every day. Cover up with clothing, hats, sunglasses, with UV protection. Stay out of the strong sun during the day, and do not use tanning beds. For when people say don't stay in there's still a risk. And then, so kind of just to add on to the A, B, C, D, E. So any spreading pigment, texture changes, or swelling or redness outside of the border are especially concerning. All right, so what about the cancers you don't ever hear about screening for? So let's say, so there are no real screening except for, I will say, oral cavity. Your dentist, whom you're supposed to see twice a year, does cancer screening on you. So when they come and they stick their fingers all over your cheeks and your tongue, that's what they're doing. They're checking you for cancers in your oral cavity. Very, very important if you smoke this tobacco, but everybody could, you can still get oral cancer. Testicular cancer, in young men, they do recommend self-exam as well. And we investigate any lump. Ovarian, there is no screening test for ovarian, except for if you're a very high-risk patient, meaning more than one family member, first-degree family member died from ovarian cancer. Your doctor can elect to do, in addition to your manual pelvic exam, an ultrasound of your ovaries every year. Thyroid cancer, there are no real screens. We do have workups for nodules, if you runs in your family, that kind of thing. Thyroid nodules are exceedingly common, but we do look and make sure that they don't look cancer. So, liver cancer, there is screening for people who have liver disease. So if you have chronic hepatitis of any kind, you get screened every 6 months with a blood test, an AFP, a marker, and an ultrasound to make sure that you don't have a new cancer lesion. And then uterine is another one that does happen, and there's not necessarily a screen, but if you have gone through menopause and you have any kind of vaginal bleeding, that is suspicion for cancer. We screen and do a biopsy. So I just wanted to touch on this real quick. All right. So now, question time.
I have a question.
Yes.
If you see a dermatologist and you've had a place removed from your body somewhere, brown spot, whatever, and they take it off, fit it in and it says it's good, should you be alarmed if the spot comes back or the place comes back?
And not so much alarmed, because they already saw that it was not atypical for any reason. If it comes back completely just a mole, it's probably not alarming that it came back. It may just mean they just didn't get it all. Because sometimes, you can't tell that unless it's under a microscope. And typically the pathologist is supposed to share that the margins are what we call clear, so it's regular tissue, but if for some reason it wasn't all removed, it can come back. But yeah, I wouldn't be concerned that that's now cancer. That's such a lively question.
Great
I was
opportunity.
expecting.
Little rough spots and scratching.
Big and black? That concerns
and
me.
darker.
Oh, yeah, you should, yeah. That,
Well, it used to just be a little place and
yeah.
took it off, and now it's a big place.
So that's that evolving. It used to be this and now it's this. That concerns us. Yeah.
There's a thing called a CA-12 or CA,
125, yeah.
can you tell us about that?
Sure, I would love to tell you about that. I get that question all the time. So that is a very non-specific ovarian test. We, for a long time, had hopes that we could use that as a screening test for ovarian cancer. Unfortunately, it's one of those things where everything elevates it. Even bowel problems, people who have IBS, that kind of thing, have a high CA-125. So it turns out that it doesn't really help. It hinders more than anything. They chase it, you get tests, you know, all sorts of anxieties and everything else, and it was nothing. And you can have ovarian cancer without that being elevated. So it's an endothelial marker, so some ovarian cancers actually don't elevate that at all. So it just doesn't really prove out to be helpful, and in fact, it can tend to be if someone just happens to want to run one, then it's positive, then you're obligated to get invasive and figure out why. Yeah, unfortunately, that's, a lot of people have the impression that that's a really good kind of cancer screen, and it's not. So I don't recommend that anybody just have that done. Now, it is useful as a marker for treatment. It's one of those, there are a lot of tumor markers like that. You may have heard of some other ones like CEA for cancer. We use those for treatment. So let's say you had ovarian cancer and your CA-125 when we diagnosed you was very high. We treat you, you're in remission, we would check that because it should always be down right after that. So if we take everything out and we treated you and then suddenly it pops up, then that's worrisome. So it's more of a marker for treatment success once you have it.
Statistically, is like prevalence of cancer actually more prominent now than it's ever been, or?
Well, yes, because we are able to test for it so much better.
Yeah.
That's right. Less people, die of uncertain circumstances. We all have those relatives. I'm not sure what grandpa had. You know what I mean? Or, we just know that it was in his bones, right? We don't know. So yeah, obviously we detect it a lot more often. I don't think that they can say it's actually the percentage, are worse because of how we live or anything like that, but just because we're able to detect it. Now, less people are dying from several cancers than they used to be, and that is true. Breast cancer being one of them, and colon cancer. Those are the huge ones where we've made great strides in mortality. Lung cancer, not really, not the smoking kind of lung cancer, not really made such great strides, unfortunately.
And this may have been mentioned, I apologize for running late. October is breast cancer awareness. So we'll have a booth down at the Elder Festival and handing out lots of literature. We got great digital mammography. Just kind of keep that in mind.
Thank you, Ted. Yeah, very good.
Where
Your
it
hand
is.
raised.
Yeah.
Yeah, it is. It's so handy. My dad actually did that on my numbers.
And yes, I'm gonna have a colonoscopy. It's been 8 years, so it's time for me to do that. So, I think last year.
Gina's keeping notes.
We're gonna make the appointment for you.
That will get done. Thank you.
And yes, nobody likes the front. We haven't got a good way to make that easier. But I always tell people it is easier than cancer. That's so funny. one day of living in the bathroom is better than that.
Right.
Sure.
Okay. Yes, I'm gonna